Usually when we say neoplasia of the stomach, the first thing to come to your mind as a clinician or a surgeon or a medical student, you think about the gastric cancer, and you're right, because the most common tumors, the common tumors of the stomach are unfortunately malignant. Okay, and most commonly gastric adenocarcinoma. Gastric adenocarcinoma account for more than 90% of the malignant lesions of the stomach. There are several lesions, several other lesions, other entities that can be malignant also, other than the adenocarcinoma, such as just tumor, neuroendocrine tumors, gastric polyps that may harbor a malignancy. والله يا دكتور إذا تكرمت تسكر الباب لو سمحت. So we'll come to everyone in details. So when we say gastric neoplasia, you found a tumor, you found a lesion in the stomach. What are the odds? What are the possibilities? What are the differential, whether it is benign or malignant? Practical implication, these gastric neoplasms or gastric tumors, they have a wide variety of symptoms that may present with. They may present with bleeding, early satiety, epigastric pain, obstruction, and they may be asymptomatic, okay? And in most of the cases, they present with non-specific symptoms, and they can be incidental finding on an endoscopy done for something or an imaging done for something else, okay? That's why careful examination of the gastric mucosa and diligent endoscopic evaluation is necessary when you evaluate a patient with symptoms suggestive of a gastric lesion. In general, gastric lesions are divided into epithelial tumors that are arising from the lining of the stomach and non-epithelial tumors. Okay, epithelial tumors like adenoma, we'll talk about it later on in this lecture, or carcinoma, or the different types of carcinoma. And here you have a separate lecture for gastric cancer. Neuroendocrine tumors, neuroendocrine neoplasm may also arise as epithelial tumors. Non-epithelial tumors, we're talking about tumors that arise from the wall of the stomach, either from the muscle or the connective tissue or from the nerve fibers inside the gastric wall. Such examples: leiomyoma, leiomyosarcoma, schwannoma, just tumors, or lymphoma, and the secondary tumors such as metastasis. Gastric polyps, they are raised lesions of the mucosa. Okay, they constitute up to 6%. Approximately they are found in 6% of a patient who are asymptomatic and having gastric endoscopy, according to the United States statistics. The majority are benign, and majority of them, they're called Fundic gland polyps. The next entity is hyperplastic polyps. A third is adenoma. يعني انت بتشوف pedunculated or sessile raised lesion from the gastric mucosa. That's by description, it's a polyp. In most of the cases, it's a Fundic gland polyp followed by hyperplastic polyp or adenoma. Inflammatory fibroid polyps constitute a minority, and only 2% of the gastric polyps, they harbor a malignancy. Hyperregenerative epithelium can result in the development of hyperplastic polyp, and we'll explain that. Hyperplastic polyps, they usually associate with pathology that cause chronic inflammation, such as H. pylori, or gastric cancer, or adjacent to gastrojejunal anastomosis, because of the chronic inflammation and chronic stimulation of the mucosa. They develop hyperplasia, and that will be revealed as a hyperplastic polyp. Okay, advanced endoscopic technique. There in the recent decades, there was massive development in the endoscopic techniques with the development of the tool itself to identify whether there is mucosal abnormality or irregularity that would suggest a malignancy. When you do an endoscopy and you observe a gastric polyp, okay, what are the odds or the chances that this may harbor a malignancy? It depends on the size. If it is more than 1 centimeter, if it is pedunculated, okay, they have a higher risk. Pedunculated means it has a stalk, okay, rather than sessile. Sessile هي قاعدة على الميوكوزا. They harbor more higher chance of a malignancy, okay. Hyperplastic polyps more than 0.5 centimeter, they should be resected. يعني انت لما تشوف polyp, you either take a biopsy بس بتاخذ منها عضة صغيرة polyp, you send it in the bottle to the histopathology, okay. But if it is more than 5 centimeter, you need to take it as a whole بالسنير. يعني انتوا لازم تروحوا على الاندوسكوبي كلكم راح تلفوا يعني either with us in the surgery او بالعمليات او بالجاسترونترولوجي لما تروحوا روتيشن اندوسكوبي الا ما تشوفوا لكم اندوسكوبي in the next 3 years. هلا you can see either you take a biopsy, a punch biopsy, or you take it the lesion as a whole, okay. هلا indication of resection of a polyp, if it is more than 5 centimeter, you need to send it as a whole because of a risk of a malignancy. هلا Fundic gland polyps, هي the most common type of polyps frequently observed up to 80%, okay. هلا بفرجيكم صورة إلها, and usually they are associated with long-term use of PPI. يعني انتوا لو تطلع على أصحابك أو مجموعتك أو عيلتك إلا ما تلقى لك واحد أو اثنين, they are frequent users of the omeprazole, lansoprazole, or Nexium, or whatever type of PPI. It's over-the-counter, commonly used medication for a common symptom, which is gastroesophageal reflux disease. هلا, the majority of these neoplasia are sporadic, okay. Minority of them are associated with polyposis syndromes, like the polyposis syndrome associated with the mutations or FAP, or with gastric adenocarcinoma. هلا sporadic Fundic gland polyps usually in association with long-term PPI, as we've just mentioned. Somatic APC mutation are detectable in 70% with the polyps associated with polyposis syndromes and mainly FAPs. يعني البيشنت بياخذ PPI وصار عنده sporadic Fundic gland polyps, rarely you may find APC mutation. بس مريض عنده Fundic gland polyps بس عنده background of FAP, there is a higher chance to find this mutation in it. هلا patient with more than 20 or younger onset of polyps, younger than 40 years, or presence of adenomas in the duodenum, okay, you have to rule out presence of FAP, which is one of the polyposis syndromes اللي هي موجودة بالcolon, so that's why they need to be investigated with colonoscopy. هلا هاي الصورة الشباب اللي حضروا معنا اندوسكوبي أو حضرتوا اندوسكوبي مع الجي آي, you commonly see these lesions. They tend to happen in the fundus, in the proximal stomach. They are almost always small, less than 5 millimeters, smooth, okay, multiple, small, okay, and in the proximal stomach. And if you go back to the history, you'll find that your patient is taking PPI, right? High is, you can see, you can tell that this is different, this is larger, the outline, the surface is not that smooth, okay, this is adenoma, Fundic gland polyp associated with adenoma. And this is a not uncommon appearance. You can see it frequently if you watch upper endoscopy. Gastric adenoma is the most frequent neoplasia lesion of the stomach. These neoplasms most commonly isolated in the distal stomach and less frequently associated with FAP, okay, than the Fundic gland polyps. يعني احنا قلنا in the upper stomach, if you see a raised lesion, هذول الحبيبات الصغيرة, هذه Fundic gland polyps. If you see a solitary or few lesions in the distal stomach, that goes more with the adenoma. The incidence of gastric adenoma associated with gastric cancer is between 10 to 60%. That's a very wide interval. That's why you need to be careful. You need to have a high index of suspicion, and you need to examine the whole mucosa carefully. Due to their malignant potential, كل gastric adenomas should undergo endoscopic resection. يعني انت كان في عندك ليجن اخذت منه بايوبسي, بعدين بعد اسبوع اجاك الهيستوباثولوجي ريبورت بيقول لك it is a gastric adenoma, you need to go back and to resect this lesion. يعني you can resect it endoscopically. هلا هاي endoscopic features of gastric polyps. A lesion, raised lesion from the mucosa. It might be a fundic gland polyp. Usually they can multiple, small, they are smooth, glassy and sessile. يعني ما إلها ستوك، يعني هي كلها قاعدة على الميوكوزا. هاي الحبيبات اللي بتشوفها ممكن تكون fundic gland polyps if they have these characteristics. When they are hyperplastic polyp, they tend to be in the distal stomach. Okay, they might be multiple, usually smooth. Okay, they might be associated with an ulcer or near gastrojejunal anastomosis, or associated with history of H. pylori or atrophied gastric mucosa nearby, and which raise a possibility of a chronic inflammation. The adenoma, usually solitary, okay? They are located more often in the antrum and velvety and lobulated. يعني if you go back, lobulated, شايفين هون يعني it's not, you can see these are more than one lesion coalesced together. Okay, this is what I mean by lobulated. This is the appearance of the adenoma. هلا ما ببين مع الجروس، ممكن الجروس appearance is suggestive لكن confirmation with the histopathology. You need to take a biopsy and to see whether you need to go back and to resect it or not. Gastrointestinal stromal tumors اللي هي اختصارها GEST. These are mesenchymal tumors. They present as subepithelial lesion. Subepithelial means يعني بهاي الصورة they are under the mucosa because they are mesenchymal tumors. They arise from the wall itself. They don't arise from the gastric mucosa itself. يعني زي ما انت تحط اشي مثلا طابة تحت سجادة او موكيت، شوف الموكيت يكون normal. This represents the gastric mucosa, while the underlying tissue is the observed tumor. So it's not uncommon to take multiple biopsies from the mucosa and they may come back as negative or unremarkable gastric mucosa. That doesn't mean that the patient doesn't have a tumor. That means that you need to take deeper biopsies or needle biopsy with the help of EUS or with the help of radiological guidance. Mesenchymal tumor does not only include the GEST. GEST is the most common entity, but mesenchymal tumors, they may include leiomyoma, leiomyosarcoma, or schwannoma, any tumor that arises from the wall of the stomach. On histology, you saw a tumor, you took a biopsy, either a normal, the routine biopsy or a needle biopsy. You always see in the GEST tumor spindle cell tumor, okay, epithelioid or rarely pleomorphic tumor. These are the characteristics of the histopathology report. Yani if you see any of these cells, that means that you're dealing with a GEST tumor because they arise from the interstitial cells of Kajal or their precursors. هلا دائما they're present في عندك immunohistochemistry staining, okay, to differentiate between different types of mesenchymal tumors. Okay, just a tumor usually express the c-KIT mutation. In a small minority of cases, if they are just and c-KIT, they may present DOG1 mutation. هاي الاشياء لازم بس تتذكر هذول الشغلتين عن الجست characteristics of the GEST and the immunohistochemistry. As we said, the DOG1 and the c-KIT are characteristic of the GEST. You may observe in the literature that the prevalence of the GEST is decreasing. It doesn't mean that the tumor is disappearing. I think it may be more because of the development in the immunohistochemistry and the ability to diagnose the different types of the mesenchymal tumors. So they are more able now to diagnose, differentiate whether it is leiomyoma, leiomyosarcoma, or a GEST. GEST tumor, it's not uncommon for you يعني انتوا اي حدا بداوم الكميه الطبيعيه من الدوام، اوكي، in the next 3 years الا ما يشوف له مريض او to observe a patient او to observe عمليه او انك تسمع زميلك اخذ من مريض جست. يعني احنا بنشوف لنا بالسنه واحده او ثنتين او ثلاثه. هلا usually the typical presentation is in the 6th to the 8th decade of life. The gist may happen at anywhere in the GI system, but most commonly in the stomach, okay, followed by the small bowel, then the colon, and then the esophagus. هلا the best prognosis are those which happen in the stomach. هلا هذا الجست, is it a benign? Is it a malignant? Okay, it depends. You can't tell. It has a malignant potential, right? Okay, but it's different from the traditional cancer. Okay, so the شباب معلش اغلبكم وين رايحين الشباب اللي هناك بالزاويه؟ والشاب بعرفش انتوا بعد يعني في لانه في ناس كلكم طلعتوا مره واحده بعد ما اخذت الغياب كلكم طلعتوا على الحمام مره واحده. Okay. The gist, it has a malignant potential. Okay, the malignant potential will depend on the several factors, mainly the site. As we said, the best prognosis is the small stomach, okay, and then followed by the small bowel, and then the colon, the rectum, and the esophagus, okay, and then the size of the tumor. If it is less than 2 centimeters, there is likely to metastasize or to recur. And to the mitosis number. يعني انت لقيت تيومر، اوكي، اخذت منه بايبسي او شلته، عملت له ريسكشن وديته للهيستوباثولوجي، الهيستوباثولوجيست بيعطيك السايز تبعه، انت بتعرف السايت، اوكي، وبيعطيك شغله اسمها مايتوسيس نمبر per high power field. If it is less than 5 or more than 5. Okay, طبعا the more mitosis number is the worse prognosis. And we'll give you a score, and the score will be reflected with the risk of metastasis or recurrence with this patient. هلا هذا التيومر per se, it has a very low chance, very low risk to go to the lymph nodes. So you don't need lymphadenectomy if you're going to resect. إذا لقيت just tumor سواء سويت CT scan أو endoscopy، أخذت biopsy، شفت lesion in the stomach. If it is less than 2 centimeter and the biopsy confirmed the just, if less than 2 centimeter, you only observe and you repeat the scan in 3 to 6 months to see whether there is an increase in size or not. Okay, and then you keep your patient on surveillance. If it is more than 2 centimeter, you need to resect, depend on the fitness of the patient. في شغلتين بيميزوا الجست عن باقي التيومرز of the stomach. That resection of this tumor, you only need to take 1 centimeter gross safety margin. يعني احنا عادة مع الجست بنعمل شغلة اسمها wedge resection. بس بتشيل الجزء من الستومك اللي involved مع الجست وتاخذ 1 سنتيمتر عنه. مش زي الجاستريك كانسر بنعمل either a distal gastrectomy or subtotal gastrectomy or a total gastrectomy عشان تاخذ 5 to 6 centimeters safety margin. بالجست تاخذ 1 سنتيمتر. الشغلة الثانية different from the gastric cancer, that with the gest you don't need to take lymph nodes. You don't need to do a lymphadenectomy. You only remove the stomach because it has a very low chance to metastasize to the lymph nodes. It is different from gastric cancer in which you need to do, for better oncologic outcome, you need to do a lymphadenectomy, right? Neuroendocrine tumors of the stomach, the incidence is constantly rising. We don't know whether it is a true rise in the incidence or it is due to the development in the immunohistochemistry or the increase in the availability of the endoscopy or increase in endoscopic procedure itself. هلا gastric net, they show proportional increase in the incidence in comparison to the net of the rest of the GI. Most of these tumors, we can see in the following table, that they have a benign course. They usually asymptomatic, benign course. They usually need only a surveillance rather than resection or a major surgery. Okay. In general, they all have a malignant potential, but it depends on the type. In this table, you see that if you diagnose you saw a lesion, okay, usually it's a subtle lesion, okay. In most of the cases, less than 1 to 2 centimeter. Okay, that's why you need to examine the gastric mucosa carefully. If you see a lesion similar to this or any abnormality, you need to take a biopsy. If it comes back as a neuroendocrine tumor, you need to see which type of neuroendocrine tumor is this. The most common type is type 1. The histopathologist will tell you that it's a grade 1. It is often small, between 1 to 2 centimeters, and multiple. And usually, if you take biopsies, which is a mandatory to take a biopsy from the surrounding mucosa, they usually come back as chronic atrophic gastritis. In type 2, again, they are small, polypoid, and multiple, but the histopathologist will tell you that it's better. It has a more chance to be grade 2, okay, with the differentiation. The risk of metastasis is between 10 to 30%, and if you take a deeper assessment of your patient, you may find symptoms of a gastrinoma or MEN1. Type 3 is the largest one. If you see a lesion more than 2 centimeters and you take a biopsy, it comes back as a neuroendocrine tumor, they are more likely to be grade 3, poorly differentiated. The risk of metastasis is between 50 to 100%. They're not associated with any specific symptoms, and luckily the incidence is between 40 to 25. They're not, but most are the type 1, which has a benign course. زي ما قلنا لكم, you need to be careful when you examine the gastric mucosa. For any lesion like this, you need to take a biopsy. Gastric lymphoma, okay, it may either originate from the gastric wall itself or from the adjacent, the perigastric lymph nodes. Okay, lymphoma, you all know that we have two types of lymphoma, either Hodgkin lymphoma or non-Hodgkin lymphoma. More than 40% of the non-Hodgkin, they arise from extranodal locations, and the GI is the most common site. Okay, they tend to happen in the West. The most common GI site for a lymphoma is the stomach. In the Middle East, it tends to happen in the mid-small bowel. Okay, they go a little bit distally. The maximum incidence usually in the 5th decade, okay, with no gender differences. H. pylori associated with one of the types of lymphoma, it's called mucosal associated lymphoid tissue, malt lymphoma, accounting for about 90 cases. Okay, this usually in the grade 1 cases, the treatment is only eradication of the eradication of H. pylori, and that would be enough. As a treatment, the malt lymphoma will subside. Okay, and usually it is associated with the antigens CD19, 20, and 22. Okay, acquired or congenital immunosuppressive conditions such as HIV, or a patient such as inflammatory bowel disease on long-term on immunosuppressant treatment, they may develop lymphoma in the GI or in the stomach. Okay, beta cell lymphoma are only low-grade lymphomas of the stomach, whereas the majority of gastric lymphoma belong to high-grade beta cell lymphoma. Again, if you see suspicious lesion, observe. This is the pylorus. This is distal stomach. This is represent ulcerated mucosa and underlying overgrowth of the lymphoid tissue. Symptoms usually, as we said, You don't need to wait for typical symptoms. In most of the cases, they are non-specific: discomfort, nausea, or sometimes they may present with a large mass in the advanced cases. Okay. هلا treatment depend on the in the pathologic classification according to Ann Arbor classification. زي ما حكينا early stage mild lymphoma usually they resolve with eradication of the H. pylori. Advanced mild lymphoma they may need radiotherapy and or chemotherapy. هلا surgical treatment of the lymphoma, usually it's not routinely indicated unless there is a complication such as bleeding or perforation or obstruction. Or rarely, even after the chemotherapy, when the tumor dissolves, they may develop a perforation and they need surgery. هلا secondary neoplasms of the stomach, do they occur? Yes. Okay, they are rare, but still they can happen. Okay, as a metastasis from other organs. And most frequent, they are rare, most frequently observed from breast cancer, especially lobular carcinoma. مش بتعرفوا إن في عندك invasive ductal carcinoma or invasive lobular carcinoma. Lobular tend to metastasize to the stomach, followed by the melanoma or the lung cancer. So, the take-home message, in addition to whatever mentioned in the slides, you have to be careful with the stomach. Unfortunately, tumors of the stomach, more than 2/3 of tumors of the stomach, once they are diagnosed, they are already in an advanced stage. So if you are a good physician, a good surgeon, a good doctor, okay, you need to have a lower threshold to investigate any symptoms suggestive of a gastric pathology. يعني إذا بتشتغل in the UK, and we almost follow their guidance. If you have a patient more than 50 years old, okay, if they have dyspepsia, which means it doesn't necessarily need to be pain, okay, or vomiting, even a discomfort is enough indication to refer for endoscopy. Okay, endoscopy is a simple procedure with a very low incidence of complications, alhamdulillah. So you just need to refer for an endoscopy to rule out gastric pathology. هلا إذا طبعا في عندك المرضى اللي بيكون عندهم alarming features such as what? Anybody? Weight loss, excellent. Weight loss, yeah. Anything else? Elderly, weight loss, bleeding, whether it is hematemesis or melena, okay. A patient with risk with family history of polyposis or a gastric cancer. These are all patients with alarming risk factors to be investigated for cancer. إذا إجاك مريض, okay, you have to have a lower threshold to investigate if they have these factors, or even a patient without risk factor and having dyspepsia that's not resolving with the conventional treatment. ما ينفعش تظل كل شهر يجي لك وتجدد له وصفة الأوميبرازول وتقول له خلاص بتحسن لحاله. No, if they're not improving, you have to refer to an endoscopist. هلا الاندوسكوبي بده يفوت بده يشوف ليجن, right? هلا الليجن بده يكون واحدة من الأشياء اللي احنا حكيناها. يعني in gastric cancer you may observe a small lesion or a large fungating, ulcerating, ugly-looking lesion. Okay? You may see Fundic gland polyps اللي احنا حكيناها. You commonly see. إذا بتحضروا اندوسكوبي 2 أو 3 أو 4 إلا ما تشوفوا واحدة أو 2. Right? You may see the raised mucosa اللي هي البوليبس الحبيبات هذول اللي هي الجاستريك بوليبس حكينا لكم. يا بتكون هايبربلاستيك يا بتكون Fundic gland polyp يا بتكون جاستريك ادينوما. وتذكروا الفيتشرز لكل واحدة. Fundic gland polyps بيكونوا multiple small أقل من 5 سم زي حبات العدس in the proximal stomach. Hyperplastic بتكون surrounded by atrophied mucosa, okay, أو near an ulcer, أو patient عنده long history of H. pylori, أو near an anastomosis. Solitary lesion in the distal antrum, velvety, lobulated, usually it is an adenoma. هلا الاندوسكوبيست شو بيسوي؟ بده to take a biopsy, okay, ويكتب detailed description. وهلا in a well established system دائما بيكون عندك picture, you take pictures and you attach it to your report, right? Okay. هلا بيعتمد شو برجع لك. على الهيستوباثولوجي ريبورت. يا بدها تكون يعني هايبربلاستيك بوليب، يا فندق جلاند بوليب، يا ادينوما. حكينا زي ما حكينا انه any gastric polyp more than pedunculated more than 0.5 centimeter you need to resect, okay, because they may harbor a malignancy, right? Okay, if it comes back as an adenoma you need to go back وتاخذها كلها بشغله اسمها adenoma resection or EMR endoscopic mucosal resection or snaring. برضه هذول الاشياء commonly بينعملوا بالجي اي يونت اللي عندنا. بعدين بتوديها للهيستوباثولوجيست and you treat according to the results that you see. هلا هذا بالابيثيلي بالميوكوزا لما يكون المشكله بالميوكوزا. اذا كان عندك ميوكوزا ريزد اوكي زي ما حكينا ممكن تكون sub epithelial tumor يعني something underneath the mucosa, right, such as lymphoma or more commonly the chest tumor. Again إذا أخذت biopsies من الميوكوزا ورجعوا negative, okay, that does not, you have to take a deeper biopsies such as endoscopic ultrasound biopsy or needle biopsy. هلا هذول الليجنز يا بيطلع لك gastric lymphoma and you treat according to the classification and treat according to the tumor markers, okay, treat according to the whether there is H. pylori or not and to the grade of the lymphoma. إذا كان عندك neuroendocrine tumor according to the size and the differentiation. إذا إنه small grade 1 you may only observe the patient and you do a surveillance endoscopy. If it is grade 2 or 3 you may need to resect. هلا if it is less than 2 centimeter moderately differentiated or well differentiated بس بتحتاج ما بتحتاج عملية، بحتاج بس endoscopy يفوتوا يعملوا له EMR or endoscopic mucosal dissection ياخذوها ويبعثوها للهيستوباثولوجي, right? If it is larger than 2 centimeter you need to do surgery, a formal oncologic surgery يعني either you do distal gastrectomy, proximal gastrectomy or a subtotal gastrectomy or a total gastrectomy even, okay, especially if it is poorly differentiated. طبعا neuroendocrine tumors ما ينطبق على الجاستريك كارسينوما ينطبق عليها if it is poorly differentiated. لازم تاخذ الليمف نودز معها. اوكي وهاي different from the chest. الجست لا، الجست بس بتاخذها with 1 centimeter gross margin اوكي وما بتاخذ معها الليمف نودز. هذا زي سؤال امتحان يعني. ماشي. الليمفوما زي ما حكينا you treat according to the grade. يعني this is an overview of the diagnosis and the pathology of whatever you may find in the stomach, right? Okay. يعني ما فيش شيء ثاني ممكن تلاقيه بالستومك، مش راح تلاقي لك ممكن تلقى residual food residues يعني ممكن تلقى إنه or a cancer. Otherwise this include 99.9% of the gastric lesions that you may come across during your career. Right? Any questions? يعطيك العافية، شكرا.